Today we are discussing peripheral vascular disease, also called peripheral arterial disease. This refers to atherosclerotic narrowing of arteries supplying the limbs, most commonly the lower limbs. It does not include the coronary arteries, the aortic arch vessels, or the cerebral circulation. The underlying mechanism is progressive plaque formation. This causes reduced blood flow, leading to chronic limb ischemia and tissue hypoxia, which becomes more obvious during exercise. The major risk factors are smoking, diabetes, hypertension, hyperlipidemia, and chronic kidney disease. Now remember the most commonly affected arteries in exam questions. The superficial femoral artery is the most common site, responsible for about 40 to 50% of cases. This is the classic vessel involved in intermittent claudication. The aortoiliac segment accounts for about 20 to 30%. This is typically seen in younger male smokers and causes buttock and thigh claudication. The popliteal artery contributes to about 10 to 15% and is often involved together with superficial femoral disease. In diabetic patients, the disease predominantly affects the infrapopliteal vessels, the tibial and peroneal arteries. Let us move to clinical presentation. The classic symptom is intermittent claudication. This is cramping pain in the leg during walking that is relieved by rest. As the disease progresses, patients develop ischemic rest pain. This usually occurs at night, affects the forefoot or toes, and improves when the leg is placed in a dependent position. Critical limb ischemia is defined by rest pain, non-healing ulcers, or gangrene. On examination, you may find reduced or absent pulses, a cool, pale limb, delayed capillary refill, muscle wasting, hair loss, and arterial ulcers. These ulcers are painful, distal, and well demarcated. Now think of complications: critical limb ischemia, non-healing ulcers, gangrene, amputation, and very importantly, these patients have a high risk of myocardial infarction and stroke because this is a systemic atherosclerotic disease. Next is investigations, which are very high yield for MRCP. The first test is the ankle brachial pressure index. A normal value is between 1.0 and 1.4. A value below 0.9 confirms peripheral arterial disease. A value below 0.4 indicates severe disease or critical limb ischemia. In diabetic patients, the ABPI may be falsely elevated because of arterial calcification, so toe pressures or Doppler assessment are more reliable. Duplex ultrasound is used to confirm the presence of stenosis and to localize the lesion. CT angiography or MR angiography is used for pre-intervention planning. Digital subtraction angiography is the gold standard, but it is invasive and usually reserved for when an intervention is planned. Now, management. The most important initial step is lifestyle modification. Smoking cessation is the single most effective intervention. Supervised exercise therapy should be performed for 30 to 45 minutes, at least 3 times per week. Weight reduction and a Mediterranean-style diet are recommended. Medical therapy is essential for both symptom control and cardiovascular risk reduction. Clopidogrel 75 mg once daily is the preferred antiplatelet agent. High-intensity statin therapy is required. For example, atorvastatin 80 mg once daily. Blood pressure should be controlled, preferably with an ACE inhibitor or an angiotensin receptor blocker. Glycemic control is crucial in diabetic patients. Cilostazol can be used for intermittent claudication. It is a phosphodiesterase type 3 inhibitor that increases cyclic AMP, producing vasodilation and an antiplatelet effect. It improves walking distance, but it is contraindicated in heart failure. Finally, revascularization. This is indicated for lifestyle-limiting claudication that does not respond to conservative therapy or for critical limb ischemia. Endovascular treatment includes angioplasty with or without stenting. Surgical options include bypass grafting or endarterectomy. Now the key exam concepts. The superficial femoral artery is the most common site in chronic disease. The abdominal aorta is the most common source of emboli in acute limb ischemia. ABPI below 0.9 confirms the diagnosis. And remember, peripheral arterial disease is a marker of high cardiovascular risk, so aggressive secondary prevention is mandatory.